forward with our next presentation regarding the basic concepts of thyroid and breast elastography according to the current European and world guidelines. So we have in front of us two major families of elastography, and actually the tissue behave different according to their elasticity when exposed to stress. It can be the strain, so from upwards a constant pressure, and you measure how much the tissue will change in shape, and actually you make evaluation of Young modulus, or you can expose the tissue to transverse forces which induce another type of deformation, so tangential to surface, not perpendicular to surface, and you measure the shear modulus. And there are different behaviors according to the quality, the density, and elasticity of the exposed tissues. We have, when dealing with thyroid or breast elasto, two major families: strain, meaning outside induced pressure perpendicular to the lesion, and shear wave, tangential to the lesion pressure or forces, monoplan or biplan. Both strain and shear wave do offer focus details, and actually they do give indirect information. It's like a virtual palpation, measuring the density and the stiffness of the lesion, making an indirect calculation of the elasticity of the lesion. And actually the details from the tissue deformation when exposed to external pressure, regardless if it's perpendicular or tangential, and you have different type of evaluation. When we are dealing with breast, it's commonly known that carcinoma, both isolated and infiltrating, have a much bigger elasticity coefficient or a much higher Young modulus compared with fibroadenoma, normal mammary gland, or fat. We can offer two major variants, again repeating myself: the strain, when you exert an external control pressure induced or imposed by the operator from superior of the lesion. The pressure has to be constant. For example, Philips device, in which here this range, this bar column should be constant, or Hitachi device where the pressure looks like this, and you have to be between level 3 to 4 to pressure, not lower, no higher, in order to have an accurate measurement. At the end, the tissue behavior, how much or how less does it compress or change its shape when exposed to perpendicular pressure, is given in a qualitative mode and a quantitative mode. The qualitative mode is a color code map where lesions go to from stiff, from soft, very soft, category 2 of color code map, category 3 hardness is much more prone from outside to the inside, and category 4 where the entire lesion is stiff, or this multi-layered blue-green eyeball aspect typical for cystic lesions. For breast, we are using the Tsukuba elasticity score, meaning complete soft, typical for benign, a combined soft with a little bit of hardness, benign, color code stiff 2, 3, 4, and 5 with the elasticity, the vast majority of lesion, the entire lesion, or even more than the lesion seen in grayscale, and of course the blue, green, red sign. It's important to understand that elasto results do not give you a yes or no type of result. So whenever on strain elastography we will have color code map 1, meaning completely soft, this is negative risk for malignancy. Whenever we have a color code 3 to 4, which is a mixed combination of some soft and some hard images or regions, there is an equivoque or an intermediate type of risk. Whenever it's 4 to 5, it's a high risk for malignancy. You can have also for strain quantitative, meaning numbers. So when you are looking to the stiffness, it's a color code complete green, color code 1 low risk, and you make, this is a subcutaneous lipoma, you make a measurement between the lesion and the subcutaneous fat, and you have the fat to lesion ratio. This can be used especially for glandular, meaning breast solid lesion. This is a color code 2, a little bit of stiffness here, ratio with the subcutaneous fat, a very good ratio, it's 2.2. Then you can have a color code 3 with a ratio of 4.6, which is also a high risk suspicion lesion. And this is a color code 4 with a stiffness ratio of 1 over 100. These two both are high suspicion lesion, which should be referred to fine needle. Another quantitative measurement is the same, the ratio between the elasto size and the grayscale or the B mode size. For example, in this situation, grayscale is 13 millimeters and 11 millimeters, and in elasto, the length of the lesion is 18 millimeters and the height of the lesion is 11 millimeters. Whenever this is valid for another device, for example, there is a difference in size observed by grayscale, bigger size, especially higher diameter in elasto, because the stiffness is not only interesting the lesion but also the healthy surrounding tissue. So when dealing with numbers, when we have conventional ultrasound combined with elasto, both this is qualitative and this is quantitative, we will have an increase in sensitivity and specificity compared with the conventional ultrasound, and big meta-analyses have a global sensitivity up to 85% with a global specificity around 85%, and the same is valid for strain quantitative, but the problem is the cutoff values are different from different devices, and the cutoff values can be different even in the same family of devices, meaning the same manufacturer, different devices with different sensitivity. When looking into which parameter of strain should be used, even if we do ratio strain to grayscale or point color or strain ratio, there are a solid evidence for good sensitivity and specificity with great area under rock. What about shear wave? So this is the tissue is exposed to transverse wave generated by acoustic force, and actually the acoustic force is the transducer by itself. The great images that we'll see are B-plan, shear wave, explorer images, and actually the principle is the same as we did so in the modulus of Young, differences in values. We see the same in elasticity measured in kilopascals. The carcinoma elasticity, the values in kilopascal is significantly bigger compared with fat and glandular tissue. There is a small overlap here, and we will see the thresholds that are currently suggested by the manufacturers. We can have the same color code or qualitative color map, and you have to pay attention to the colors, which sometimes are different from one manufacturer to others. So blue is here soft, and red is stiff, is total opposite to the strain, the vast majority of strain devices, and the reddish the color, the higher the values of kilopascals, the higher the risk of malignancy. Qualitative code is a color code map 1 when stiff is in the entire region. Color code map 2 in which in the lesion there is not only stiff, you have these green yellowish colors here in the surroundings, so it's a mixture. The mixture more prone, this is a color code 3, and in the color code 4 the entire region is reddish. From the quantitative type of measurements, shear wave is much more generous. You can measure the mean elasticity, the minimum, the maximum, the standard deviation, and also the ratio between the elasticity of the tissue compared with the subcutaneous fat with different threshold observed. When dealing with the ratio, you might use the ratio of the entire lesion, which is a color code 3 region, although you have this region with color code 5. So in both variants, both measurements are useful, and I emphasize to when you have a stable color code map, meaning you have at least a 7-second steady exposure to the shear wave, you can have your final image, and then you can focus on the more stiff part of the lesion. Great sensitivity and specificity also described in the literature for this type of technique. Moreover, there is a general accepted threshold below 50 kilopascal, highly suggestive for benign lesion, and over 80 kilopascal, highly suggestive for malignant lesions. And again, regardless if you're using maximum elasticity, mean elasticity, the ratio or the standard deviation, the area under ROC curve for the diagnostic of breast cancer, and sensitivity and specificity of the diagnostic is excellent. The same result that do not see it a yes or no type of result, do see it in risk stratification. And there is a proposed model in 2019 saying that whatever is below 70 is highly suggestive for benign lesion. The higher the kilopascal values, the higher the risk of malignancy. Because when we are looking in elasticity, both in all mean, maximum, or even in ratio, there is a huge significant difference between the mean values of malignant lesions versus benign lesions. What is the position of the European Society of Ultrasound? So is recommending elastography as an additional informational tool, is not instead of, is adding, because there is no consensus about ratio of strain. You will never get to see a value. In breast elasto, whenever you have stiff lesions, you will refer it to fine needle, and we will see in a few minutes. There is a regrading whenever stiff and consider biopsy. And of course, there are, as in thyroid, soft tissues, which can be overlooked by elasto. The World Federation Society of Ultrasound is also recommending elasto as a complementary technique to grayscale, is not instead of, and summarizing what the major two societies are recommending currently. The European one says downstage from 3 months follow-up to 6 months follow-up whenever you see a BIRADS 3 which is soft. Downstage 4A to 3 whenever the lesion is soft. Upgrade to biopsy any solid lesion which is stiff. And of course reconfirm benignity in BIRADS 3 which is soft. What says the World Federation recommendation? Downgrade soft 3 and 4As. Upgrade whenever you see solid stiff lesions. Do not change the 4B and 5, meaning even if it's soft, when it looks like a 4B or 5 on conventional ultrasound, refer it to fine needle or to surgery. Do not change the BIRADS 2, and do not overlook the evaluation of the ductal structure up to the tumor, where you can find secondary foci and which are easily to be seen in elasto. So a BIRADS 3 should be upgraded whenever it's stiff and referred to fine needle. A 4A, due to its small inhomogeneity here, could be downgraded to, upgraded because it's stiff to 4B. A 4A, because of the polylobular shape, should be downgraded to 3 whenever it's soft. A 5 remains a 5 regardless elasto. And actually, because the vast majority of cancer are stiff on elasticity, but there are some intraductal carcinomas and mucinous carcinomas and tubular carcinomas which can appear soft on elasto. And when we're comparing a head-to-head shear wave versus strain, actually, whenever you use the cutoff 40, 50, 80, 100, so meaning very low risk, intermediate, and high risk, and the same is valid for strain elasto between 1 or 2, 2 to 3, 3 to 4, 4 to 5, actually the sensitivity and the specificity are comparable. So bear in mind also here risk stratification and not a yes or no type of response, because the difference is both in strain ratio and in elasticity ratio with strain, elasto, and shear wave are significant between benign and malignant lesion, but still there are different threshold for different devices and for different manufacturers. So this is why we will never have an only value. We will have different values for different devices. And regardless which type of color code map you have, from soft to hard in this color code or in this one or in this one, whenever you have soft lesions, color code 1 or strain ratio below 2.8, consider it Byrod's 2. Whenever you have the 3 to 4 color code and an intermediate strain ratio, consider it 3 to 4. Whenever you have stiff with increased strain ratio, consider it 5. And this is valid also for shear wave, regardless which type of color code map your manufacturing is, offer below 20 kilopascal, below 60, below 80, and over 80 different risk categories. So again, downgrade 322 for A to B, never downgrade for B, always upgrade solid when stiff, regardless which type of elasto you are using. So stratification, not yes or no. What about thyroid? We can offer the same 2 types of elasto, the strain with again control external pressure perpendicular to the tissue, and we have actually 2 color code criteria. We have the Ragro criteria with 5 color code scores, like complete soft grade 1, a little bit of stiff, but the vast majority soft grade 2, a vast majority stiff and entirely stiff grade 4, and with stiffness in a bigger area than compared with the grayscale, the color code 5. Or we can use the Austria criteria, which somehow comprise the 5 is not there, the 5 is somehow incorporated in 4, completely soft, especially so majority soft, majority hard, and completely hard. We can also have the same stiffness ratio, but in comparison to breast, we are using the healthy surrounding tissue at the same level, and we have the same ratio, which can be, as the higher they go, the higher the probability of malignancy. There is also no clear cutoff point of elasticity is called different elasticity values but good sensitivity and specificities. And when we look here comparing each conventional ultrasound characteristic with elasto, so stiff is specific for cancer, soft is specific and sensitive for benign lesion. What about shear wave? The same transverse wave generated by the ultrasound, by the transducer itself, and the force is tangential to the lesion, and also the lesion will have a different deformation according to its own elasticity. And again, you can have a quantitative color code map, so completely soft here, intermediate soft and hard color code 2. The vast majority of the nodule is hard color code 3, and of course very very stiff the lesion colored core 4. We can have also elasticity measurements. We have the same minim, medium, maximum, and also the ratio with the healthy surrounding tissue. So it's the same principle like in breast, but you're not comparing with muscles, we are comparing with healthy surrounding tissue. The problem always in shear wave is the tracheal cartilage, which is a stiff area and will alter this peritracheal part of the thyroid. Regardless if you are using RAGO or Asteria criteria, you can always consider a low risk, like a 6 criteria for the thyroids of risk category whenever the lesion is soft or very soft, like this blue, green, red evaluation. This is valid also for shear wave, the color code 1 color map. Intermediate risk, whenever you have color code, this is a 3, this is a 2, this is a 2, this is a 3, and this is valid also for category 2 in shear wave, 2 to 3, here is a 3, here is also a 3. All are intermediate risk. And high risk whenever the vast majority of the lesion is hard, regardless how they look like in strain, or the same is valid in shear wave. Here is the nodule, here is the nodule, here is the nodule, and also here is the nodule. So very, very stiff lesion. Different stiffness ratio or elasticity ratio for different devices. European guidelines emphasize that for thyroid there is an additional tool, but you will never get a recommendation about the stiffness ratio value that you can use, because it's different for different devices and different manufacturers. Intralesional calcification do limit strain elasto, but do not limit shear wave elasto. For example, for strain, different cutoffs for malignancy with different sensitivity and specificity. For shear wave, different cutoffs with different sensitivity and different specificity. So you will never see, and I do not think that we will see in the near future a very clear value, but again, think about risk stratification and limits, interval, and not a yes or no type of response. The same goes for the World Federation guidelines, considering elasto should be used in combination with conventional US. And whenever you have a stiff lesion, you should refer to fine needle. And do not forget there are some papillary carcinoma misleading soft, because you do not have a 100% type of confidence, not even in elasto. And even the American Association of Endocrinology is stating since 2016 that elevated stiffness has to be considered among the risk categories, the high risk categories of nodules, along with solid pattern and other type of suspicion ultrasound features. Additional tools, stiffness should upgrade to fine needle. And also do not forget, it's a helpful tool about which nodule to refer to fine needle, what we discussed earlier. The stiffness should recommend fine needle. Between these two nodules that look, let's say, low risk and very low risk in conventional ultrasound, the stiffer one should be referred to fine needle, and this is valid even if you look it in strain or in shear wave elasto, also in this situation. So this is an intermediate risk nodule, this is a intermediate risk nodule. This one is stiff, this one not, and this the same image. It's a softer tissue, lesion, the first one, and the stiffer lesion, the second one. So this nodule should be referred to fine needle and not the first one. Always combine it with conventional ultrasound. It can reveal some mute carcinomas on conventional ultrasound, increases the risk stratification and nodular goiter. For example, the French TIROID, which has the 6 risk characteristic, high stiffness, has a better calculated risk capability of differentiate cancer for benign lesion when referred to this model, and especially when we look here, sensitivity, and specificity significant better for the combined with ultrasound with elasto risk stratification than the other ones. This is valid also for intermediate cytology, so combining the information of elasto will enhance your diagnostic accuracy. What about head-to-head comparison? So when we look to quantitative score, so whenever you have thyroids cutoff over 3 or 4A with a strain with shear wave better sensitivity, enhance the sensitivity also the shear wave. When compared head-to-head, regardless if you are losing the mean elasto, the maximum one, the strain ratio, the Asteria score in strain elasto, or the strain ratio, we have significant differences between the mean values in malignant lesion versus the mean lesions values in the benign lesions. And regardless if you are using shear wave with this type of threshold or strain with this type of freshen, both accuracy for strain and shear wave where combined with conventional ultrasound is excellent. So it's not a matter of which elasto is better, it's a matter of using stiffness regardless if you use it strain or shear wave in order to enhance your diagnostic accuracy. Because at the end, even if you're discussing about breast or thyroid, it improves the diagnostic accuracy, it adds information to conventional ultrasound. The general rule is whenever stiff, you have to refer to make an upgrade of the risk and refer it at the end to cytology if it's fine needle in thyroid or true cut in breast. There is no universal threshold, neither for strain nor for shear wave that is generally recommended. Please again remember risk stratification, interval of values, and not a yes or no type of decision. And do not forget that both in thyroid and in breast, they are still soft cancer that can be overlooked even by elasto. Thank you very much.